it has the patient information and the physician information. And there's about 50, on the requisition, there's about 50 drugs that you can actually check on the requisition, and then they will actually highlight these drugs on the first page. So the patient would have actually been on Plavix, warfarin, Celexa, and Celebrex, okay? And most of the physicians don't know what gene these drugs are going through, okay? The first time I ever delivered a report, we didn't have the drugs, and we just had the genes with the metabolizer status. And the doctors are like, Ed, what is this? I have no idea what 2C9, I don't know what any of these drugs are going through. And so I had to go back and get about 250 of the most commonly prescribed drugs and their pathways, and we still have that. But we're making things easier every day, and there's actually a PharmD overread that we can provide as well with a complete, medication list if they want that. But right now we'll give the doctor the implications of the drug with the gene and the metabolizer status, and actually therapeutic recommendations here. So what we do is we look at 5 or 6 genes, and these 5 or 6 genes metabolize 75 to 80% of all the medication prescribed on the market today. Okay, so 2C19 is one pathway that processes medication through the liver, and we actually gave green for go. There's red now, has a stop sign. There's a yellow that is caution. But if you're green, you have a normal metabolizer status, and therapeutic recommendations. They have it broken down into cardiology, pain, psych, and urology, where everything's good to go there. But if you're a poor metabolizer of a pathway, which this patient is a poor metabolizer at 2C19, talks about reduced metabolism and increased level of anti-inflammatories, and you have risk of GI bleeding for pain meds and psych and urology. They break it down into 4 major categories: cardiac, pain, psych, and urology for these pathways. So you have 2C19, 2C9. You have 2C9 with VCOR C1, which is there's a package insert on warfarin, and you need both of these genes to come up with the initial dosing of warfarin. And the initial dosage of warfarin can vary from a factor of 10. It can go from 0.5 to 2 all the way up to 5 to 7 milligrams based off your genetic test. And the Mayo Clinic did a study on 3,500 patients that showed if you use this result right here with your initial dose, you get the patient to a stable INR 2.7 days faster, it stays in range longer, and you reduce hospitalizations 31% within a 6-month window. 2D6 is a pathway that metabolizes roughly 30% of all the medications out there. A lot of your pain medication and beta blockers go through 2D6. This patient happens to be a rapid metabolizer, so it breaks down, for cardiac, the 4 major categories, and gives you recommendations. So if you're a rapid metabolizer of 2D6 and you're looking at a pain medication, it tells you consider an alternative drug like methadone, which goes through 2C9, or fentanyl, which goes through 3A4. Okay. One way to look at this, especially with the weather we just had, is right now we have a busy road out there. There's a lot of cars on it, or things just aren't moving fast. Okay, so it's a poor pathway right now. Well, if there's a pathway that's open, okay, you can get there more effectively through a different pathway. So in Atlanta, we're looking at where I live, we're looking at pathways pretty strongly the last couple days, okay? So there were certain areas that you just couldn't go down, okay? Like 2D6, okay? If that was a pathway that that just wasn't moving, it didn't matter how many, you just can't get down through that pathway, and it applies to medicine. So for physicians, if you have a pathway that you're either a non-metabolizer or ultra-rapid metabolizer, for a lot of these patients, it doesn't matter how much more medicine you give them that goes down this pathway, it's never going to work. And that's what Dr. Trescott in that pain presentation talks about. She was a non-metabolizer of the 2D6 pathway. So she went for surgery and she was in extreme pain. They kept giving Loratab, which goes down through 2D6. And, hey, I got, more relief from 2 glasses of wine than I did from all the Loratab they would give her. So this is where it can help orthopedic surgeons and spinal surgeons that are giving out pain medication, or emergency room physicians. If you knew the metabolizer status and you're giving pain medication and you have a pathway that isn't responding well, you need to use a drug that goes through a different pathway like 2C9 or 3A4 because they're normal metabolizers here, okay? So you have 3A4 and 3A5, which are 2 other pathways. And then we also have 4 risk factors that we look at. ApoE is a gene that we look at that helps with statins selection. And if you have an ApoE E4 result, there's a publication in CERT that's in the Life Care Test website that says that these patients only respond well to simvastatin. It's a generic drug, so there's Merck isn't going to be promoting the fact that use our generic drug on these patients, which is 16% of the population. And then also the E4 patients have a higher risk of developing Alzheimer's as well. Factor 2 and factor 5 are risk of thrombosis and thrombophilia. So the orthopedic surgeons and spinal surgeons love that because these patients are the patients that would have the high risk of a pulmonary embolism or a DVT. So if they're able to see these patients in advance and know that this is my high-risk patient of the year or of the month, then I'm going to medicate them in advance before even operating on them, because I'm going to completely eliminate that high-risk patient from being high-risk, because I'll give them some type of blood thinner before the procedure. And then we also look at MTHFR. And then what AI Biotech did was the patient ID card, which I showed you earlier, gives you your metabolizer status with the pathways, and then your doctor's name is going to be right here with the patient's name. So this is going to be in their wallet